I'm pleased to introduce Dr. Daniel Baer, who holds a PhD in social policy from the London School of Economics and is a professor at Humber Polytechnic in Toronto. Dr. Baer has conducted extensive research on medical cannabis use, drug education effectiveness, and the enforcement of drug laws. Dr. Baer leads the National Pharmacists as Cannabis Educators Project, which work to equip pharmacists with the tools they need to support and educate cannabis consumers more effectively. Dr. Baer's work highlights the urgent need to shift how we educate both providers and patients so that clinical environments become more supportive, inclusive, and informed when it comes to cannabis use. Please welcome Dr. Baer.
Yeah, I'm going to grab them. I'm going to use the wireless mic here because I hate getting trapped behind a lectern. I'm very sorry to the camera crew there. So thank you so much for having me today. I just want to say that though I do work at Humber College today, I'm not here representing Humber College or their beliefs. Read into that what you will. So I do want to acknowledge, though, that my works is situated in the traditional treaty lands of the Mississaugas of the Credit, the Anishinaabe and the Haudenosaunee. Etobicoke was originally known as the place of the alders in the Michisagi language, and today is a vital source of interconnection for people from around the world. As was mentioned, I do lead a couple of different projects right now. The Pharmacists as Cannabis Educators project, which Dr. Urban started talking about, and I'll mention a bit more in a few minutes. And then I also lead a combined team, which is called the Cannabis Education Research Team, which is comprised of folks from Humber and at Memorial University, where we're working together to deploy more effective cannabis education tools. I do want to acknowledge that I have current funding from NSERC and that I have partnerships with the Canadian Pharmacists Association, CSSDP, Canadian Centre for Substance Use and Addiction, and also the Canadian Public Health Association. I will point out that none of those four groups have given me any money recently, but NSERC is sort of our bread and butter in the college system. So today I'm going to talk about four main areas, and the first is understanding the past failures in drugs education. We're going to look at some concerns and knowledge needs for cannabis consumers. We're also going to consider the role of healthcare professionals, which, given the population in the room, is something I'm sure you've all done a bit of consideration already for as well. And then we're going to think about a new approach here. And I'm not going to be talking so much about the science today. It's a little bit more about the soul. And I think it's an important area of examination. So this was me in 1998. Actually, I think this picture was 97. And I'm playing baseball for the Venice High Gondoliers in Los Angeles, California. Venice High School is the setting for two very well-known movies in history here. The first one being Grease, with John Travolta and Olivia Newton-John. All the, shooby-doo-bop-bop, that all happens at Venice High School. And then the other film shot there is American History X. So two very, very different films, same location. It's where I grew up. It's what happens when you grow up in Los Angeles. All of your places of your childhood are associated with different film shoots. And in 1998, I was at a Halloween party, and a bunch of guys showed up who weren't supposed to be there. And they started attacking one of my friends, 6 guys. And being the naive 16-year-old that I was, I tried to break up the fight. Hey, stop this. And said they turned on me. And I don't know how many of you have ever been punched in the face before. I don't recommend it. I especially don't recommend it when it's 6 people punching you in the face. And I managed to stay on my feet for, a little bit of time. But I got knocked out. And when I was knocked out, I got kicked in the face repeatedly. And, it's something that hurts to this day, physically and emotionally. It literally still hurts to this day. It still hurts to sneeze. And I had broken bones in my nose, my orbit, my cheek. My sinus was crushed in a bit. I basically looked like a plate of hamburger by the time they were done. And with that came PTSD, came reconstructive surgery, came OT, occupational therapy, And I was 16. And you know, when you're 16, we forget this now that we're adults, but when you're 16, you think you're freaking invincible, right? Like you forget that the world can do things to you. That's why 16-year-olds do so much stupid shit, right? They don't realize what can happen to them there. And I didn't know who to turn to because after a couple weeks of not sleeping and being given opioids, because it was the 90s, they were like, here, take some opioids, you'll be great. And I couldn't go to school, I couldn't function. But a friend came over and said, do you want to get high? And I'd smoked cannabis twice before then. The first time I didn't feel anything. The second time I watched the movie Heat and found it incredibly fascinating. And then called the girl who we were both kind of crushing on each other and explained the plot of it to her point by point by point. Might not have been my smoothest move ever. But I didn't know who to talk to because all of a sudden the cannabis was working. It helped me sleep. It dulled the pain, mentally and physically. It allowed me to go to school. I could go to school, but I couldn't tell the teachers about my miraculous recovery and return to education. My nose was still somewhere over here, but I was able to go to school, and I couldn't tell anybody why. And who could I talk to? And I want to point out my innocence here before this as well. A year before this at a Doobie Brothers concert, I had turned to my cousin and said, why does it smell like burnt barbecue chicken in here? Not 6 months before this incident, I had asked my dad, what's the difference between weed and marijuana? I was pretty innocent. But my friend had provided me cannabis, and it was helping, and I couldn't tell anybody about it. I couldn't talk to my parents, lovely folks that they are. My father had very clearly said to me that if I ever catch you with cannabis, I'll take you to the cops myself. Okay, now I go to his house in California, mind you, and he and my mom each have like 4 different kinds of gummies that they like, depending on like if it's sleep or knee pain or whatever it is. That was not what it was like in 1998. I couldn't go to my pediatrician. I mean, first of all, I was 6'3" and 198 pounds. It felt a bit weird to be sitting on the little kid chairs. But also, he was a lovely man, very caring and very sweet, but he knew nothing about drugs other than telling me, don't do drugs. I mean, like he was just, you know, he had maybe 2 extra words beyond Nancy Reagan's just say no, but that was about it. I couldn't talk to the counselor. I tried talking to him. It was this cool young guy. That's not a picture of him, that's a stock photo. I couldn't find one. But he thought, you know, he was all cool, you know, and he tried to tell me how hip he was. He gets me, right? He was in his early 30s, was recently out of the Navy, had slight hearing damage because he had worked in engine rooms and Navy ships. So he talked very loud about how cool he was. And when I tried talking to him about the cannabis use, he told me I was destroying my brain and that I'd never be the same. Yeah, couldn't really keep talking about it to him. And I sure as hell couldn't go to the DARE officer at our school. I mean, in high school in Los Angeles, it was literally 21 Jump Street. They had undercover cops there. They'd tell you, hey, can you sell me a dime bag before this party? And then at the end of the year, they'd round up all the students that they'd arrested. And it turns out that, you know, the kid who had a 5 o'clock shadow at 8:30 in the morning was in fact a police officer. So there was no one to talk to. And that's where I come from today in talking about some of the things that I've been researching, because I had no one. I had to learn about cannabis myself, and there wasn't that much information out there in the late 90s and early 2000s. We had just passed medical cannabis laws in California 2 years before this, right? There was no way in hell I was getting a recommendation as a 16-year-old. So what did I do? I was alone. And it was scary, and I started doing my research as best I could. And it's what put me into this career today of 20 years. Well, it's 20 years since I entered it professionally, but I guess what we're at, 28 or whatever since I got introduced to it. But it made me think about the failures in drugs education that got us here. In the 90s, there was a lack of clear guidelines. People didn't know what they could use, how they should use it. Physicians weren't being trained on this. It was sort of a wild west, right? In California, you could get a recommendation for pretty much any reason, given the way that the legislation was written, but no one really knew how or how to dose it, anything like that. It was kind of like, yeah, go out, do your own thing. 2000s, we saw continued insufficient training, a bit more frameworks around how to actually get people to have some benefits around cannabis. 2010s, we started seeing a bit more frameworks, but there was also a lot of misleading information out there, right? I feel like the 2010s, all I heard about was how amazing CBD was, but no one knew exactly why, but it could cure anything and everything, right? But listen, there's obviously clear benefits to CBD. No one's denying that. Whether it needs to be infused into your bed sheets is a different story, though, right? Probably not so much bioavailability there. But the 2020s now, and this is where I'm focusing here, I think what we're seeing is an emerging need for more than just evidence-based education on cannabis. We are still living, and this was brought up already, under the stigma of a century of prohibition. We have alleviated the legislative burden, but not the stigma burden. And this is where we are stuck. And so much of this clinical research, so much of the preclinical research is amazing and powerful, and the findings there, between what Dr. Sethi was talking about the experiences in clinic, what the other presenters have talked about with the mice or the rats or wherever, all of those things have to get through the door of stigma and prohibition mindsets. And that's where I think we can make an advancement today. So one of the ways that we started doing this in my research is we built a campaign called Weed Out Misinformation. And we built this by asking cannabis consumers and bud tenders and public health experts, what is it that you want to know about cannabis? What do you know already? And how do you want that information delivered? And so we built Weed Out Misinformation. We have this nice website here. We also built out materials that are, at least our legal counsel says, are okay to be deployed in a retail environment, because we know people are going to their bud tenders. So I've got two items here. The first is our first-time consumer checklist. And bud tenders love this because they don't want to have a 30-minute conversation with a new cannabis consumer. But this starts from a harm reduction and mindfulness and benefit maximization approach. The first thing on here, that's point 5, but the first thing says, I have selected a method of consumption that is right for me. That's the first point on here. The whole idea of this checklist is that someone can go through this and ensure that if they're going to be consuming cannabis for the first time, they understand a whole variety of topics and issues and areas that they can look at and explore to ensure they have a good and safe experience. We ask, I have selected a strain that will provide me with my desired effects. We can get into strain discussions there, that's a whole other thing. I've considered how the setting I am consuming in will impact my experience. Our drugs education does not talk to people about set and setting, but anybody in here who has studied drugs knows that set and setting is an incredibly important area of discussion. I was thinking, Dr. Cutler, when you were talking about the knowledge about what cannabis is, think back to Howard Becker's discussions in the 1950s on becoming a marijuana user and people actually having to understand what it means to be intoxicated with cannabis. They have to learn what that feeling is. And that's something we have to help people understand and understand what that means in different settings for them. I mean, I know plenty of people who will say, oh, I don't drink tequila, it makes me too wild. It's not the tequila, it's the fact you're drinking tequila in like a party setting. That's why you're going wild with tequila. The same thing happens for other drugs as well. The other pamphlet that I brought with us, this is one of many that we have here, is from our new buds consumption checklist and pamphlet. This one talks about set and setting as well. We differentiated between new consumers and experienced consumers in a lot of our material because our research identified that their needs, not surprisingly, are quite different. The new consumers needed things like, what is THC, what is CBD, what is the difference between different strains, what is set and setting, what is my purpose for consumption? If a person is consuming because they are having horrible pain related to their oncology treatments for cancer, their needs, their reasons for consuming, their expectations are going to be vastly different than the person who is, trying to watch the only film in which Al Pacino and Robert De Niro appeared together, right? Like there's a very big difference there. So I highlight those amongst many others that you can find on our website. Everything on Weed Out Misinformation, because it was paid for by a grant from the Canadian government, is Creative Commons license. So anybody can download any of our posters, pamphlets, checklists, whatever they want. They can utilize them however they want. It's there to be used and to be used in either retail settings or home settings. We also built in, because people told us they wanted to get rid of myths. They were so confused by all the myths out there. They wanted help understanding what was true and what wasn't. So we centered the website around the idea of myth. And then we also made sure that we have 2-minute videos on there where cannabis experts are able to deliver information on different myths and how to sort of see through the smoke, as it were. We were going to go longer videos, but we realized that people don't have attention spans past 2 minutes, so keep it short and sweet, right? Let's see if I balance this. Okay. I'm tempting fate here by balancing my water and leaving it open. So if it all goes to hell, well, I'm sorry for the next speaker. Also, the great part is we used Humber's creative advertising students to build all the content. Everything on Weed Out Misinformation was built by young people who consume cannabis or who are part of advertising, and I'm pretty sure most of them did consume cannabis based on the way they talked to me about it. But the nice thing is when you use creative advertising students, they drop in little Easter eggs, like making an avatar of you as one of the characters in the actual materials. We used all these different avatars to represent different types of consumers who then answered specific questions. So we had a barista who was a new consumer. We had the cool aunt who was there to help guide you. We had the nurse practitioner, not a physician, because our respondents said they didn't like talking to physicians. But we had a nurse practitioner who was there to provide you medical-focused advice or guidance. But the nice one is they did sneak one in and surprise me with this one. And if you notice, his books say start low, go slow. So that's the professor character. One of the things we did see in the Weed Out Misinformation research that we did was that people were going to their friends not because they trusted them the most, but because they were the most accessible. And okay, there's some value in there, but they wanted experts. They told us repeatedly in the focus groups and in the survey data, this was 1,598 respondents. They told us overwhelmingly they wanted information from experts. They liked it when there was a citation. They liked it when they could see a reference list. They didn't have access, though, to journal articles and things like that. And when they did, they often reported that they didn't understand all of it. They needed people to translate that large-scale scientific information and bring it into terms they could utilize and actually apply in their cannabis consumption practices. They wanted to make sure they were doing things in as safe a manner as possible, and they weren't getting that kind of support. And so we started thinking about, like, what do the consumers tell us they need? They talked about all sorts of things around dosing, storage, driving, interactions with medications, and I was thinking about all of this, and it took me back to some of my initial research with cannabis, which took place with the Women's Alliance for Medical Marijuana in Santa Cruz, California, in the summer of 2004. How many people here have heard of WHAM? Anybody? Couple hands? Not many. WHAM was one of the first dispensaries and collectives in California. And in fact, for a short period after the DEA raided them, they then had an injunction from the federal courts making them the only legal medical cannabis grow site in the United States outside of the University of Mississippi. And this is Mike Corral. This is standing in front of the acre of cannabis, the field that would grow an acre of cannabis. This is the winter cover crop on there right before we tilled it into the soil. And I did a year-long ethnography with the folks at WHAM, learning how these terminally ill patients worked together to provide cannabis free of charge to one another. But the issues that those folks were dealing with were the same ones 20 years later that our consumers were telling us they needed. That represents a horrible failing on our part. If people 20 years ago, under a prohibitionist model, growing cannabis in secret in the foothills of Santa Cruz, California, have the same needs and are not getting the information they need 20 years later, that's a real issue in my mind. Thankfully, the folks at WHAM had each other, and they had the support network that was built in there. That's one of my major critiques of the current model of cannabis legalization here in Canada, is that we've destroyed the opportunities for supportive networks. If you look at the dispensaries when they were operating, the cannabis buyers clubs and places like that, those were hubs for knowledge where patients could find support and care. And if any of you have ever been sick, with cancer or anything else like that, you know that there's the care from the medical practitioner you need, but there is the care from other humans that you need as well. And we need to be able to marry those things together and not separate them out. This brings us to the Pharmacists as Cannabis Educators project, because under the Weed Out Misinformation campaign, people were telling us we need people who are experts. We need medical guidance. We need information from folks who know what the hell they're talking about. And we realized they didn't want to go to their doctors. They were telling us they were having really stigmatizing experiences with their physicians. We thought about it, like, who could we then get them into? And we realized that pharmacists are a low barrier entry point, right? There's 48,000 pharmacists across Canada. You don't need an appointment, and they're in basically every town that has a population over about 300. You have pharmacists everywhere. I also jokingly say that, you know, a pharmacist is very different than a physician. The physician has probably seen you naked. Your pharmacist probably hasn't. And so there is an intimacy difference there between the two. I know that when I turned 40, my pharmacist suddenly knew my name, even though I didn't remember his. And so they do know you. They have a lot of information. They're highly trained, right? People tend to underestimate the training that pharmacists have. How many pharmacists in the room right now? Rock on. I think it's one of the most underrated professions in the medical field, because people think it's about counting pills and being like, all right, there you go. But it's so much more than that. My father was a drug rep for GlaxoSmithKline back when I was a kid. Well, back then it was SmithKline in French. So I visited a lot of pharmacies, dropping off a lot of golf balls and pens and whatnot back in the day. And one of the things we were thinking about, though, is that the pharmacist can be this great avenue. And so we conducted our research, again, about a sample of about 1,500 in our survey on this next project. And we saw a gap emerge. And the gap is this. About 6% of people that we talked to said, I've gone to a pharmacist to consult about cannabis. We thought, that's great, 6%, that's still a lot of people. And we asked them, we said, would you go to a pharmacist in the future? And 42% said, yeah, I'd consider going to a pharmacist in the future. Most of them said, though, if that person could demonstrate that they had been trained in cannabis, that they weren't just sort of, you know, saying whatever or reading off a script, but that this person had received training and was, you know, displaying a if not expertise, then a level of proficiency. The problem is, though, sorry, forgot I had that animated cannabis leaf there. The problem was, though, that 58% of people we talked to said, yeah, I'll just go to the bud tender. I'll go to the dispensary. It's easy, it's quick, I'll just go there. They're obviously, though, not getting the kind of service and care and information and support that they need. Even with our Weed Out Misinformation materials placed in a retail environment, they're not going to get the same kind of care and support that they can get when talking to a pharmacist or other medical professional. So what are the roles that healthcare practitioners can play in educating individuals, in promoting safe consumption, and ensuring that people get the benefits from cannabis that they are seeking? We've broken it down on our team to thinking about awareness, education, guidance, support, advocacy, and almost more important than any of these is destigmatizing the use of cannabis. One of the biggest issues we found in our Weed Out Misinformation research was this problem of stigma, that once people had tried to get help from a physician in particular, but other medical professionals as well, they were feeling stigmatized, and that pulled them away from care. It pulled them away from a sense of wanting to seek out information, and they went back to their friends, they went back to the bud tenders. And we need to pull them away. We need to make sure that every interaction that an individual has with a healthcare professional has the potential to leave them with a positive experience. So part of the way that I've worked to do that is I worked with the Canadian Public Health Association to write what we called Cannabasics. And Cannabasics is a primer. It is not, you know, you are not an expert on cannabis once you've read this, but it's about 20 pages written from a harm reduction and benefit maximization perspective, teaching healthcare professionals how they can effectively engage with people who are considering or consuming cannabis. And we wrote this because so many people were saying, I go in and I talk to my doctor, and my doctor's like, I don't know, it's not really my area. Go talk to a pot doc, right? And that's great, like doctors who have built that specialization, who have built those practices, that's great. But that the individuals are leaving stigmatized. So this is a primer. It is, again, you know, gives you the basics, understand, like, we start off at like, what is cannabis? It's a plant. There are male and female cannabis plants. Like, that's the level we're starting off at, assuming zero level of knowledge. And I find it's been well received so far. I've got the QR code to make it nice and easy to download. Keep a copy with you if you, I'm sure the problem is I think this audience probably is well past the primer level of cannabis, but, you know, pass this along to a friend who might need it and see how they react to it. But what this and Weed Out Misinformation and a few other projects that I've worked on recently have done made me think that we needed to move past our current frameworks. Because as I mentioned before, our current frameworks are based in a prohibitionist mindset. Even taking a harm reductionist approach, harm reduction is a child of prohibition. Harm reduction, the great things it has done for people potentially exposed through intravenous drug use or consuming of opioids or whatever, harm reduction works really well when you're talking about opioids, right? You can die if you have too much opioid, right? It is acute, it is quick, like it is not something that happens 10 years down the road. We're not talking like lung cancer and cigarettes here. We're talking you die right now. And so it makes sense for us to talk about harm reduction. But cannabis is much more nuanced. It's much more difficult to use and talk about harm reduction in that context, right? You will not die even if you smoke 4 fat joints in a row. Like you might be tripping pretty, but you're not gonna die. Like you're gonna be out there, but you're gonna be okay eventually. Actually, I will point out that on the Weed Out Misinformation website, the most popular page on there is the green zone, as we call it. It's a page for people who are greening out, and it has an 8-hour playlist on Spotify of chill music and a list of 10 things that you can repeat to yourself, and it starts with like, you are not going to die. You may be feeling very unwell, but you are not going to die. And so from this, we conceptualized and built what we call mindful consumption and benefit maximization, which I think is the next paradigm that we can utilize to effectively educate and engage with people who are using drugs, particularly cannabis. And the idea of mindful consumption and benefit maximization is that if we engage people to understand and think about intentional and informed use of substances, we talk about this from a position where we respect their autonomy, we avoid stigmatization, and we encourage reflection on their drugs use. And we pair that then with a question around benefit maximization, asking them effectively, what is it you want out of this experience, and how do we maximize that benefit that you're seeking, which inherently includes a reduction in the potential harms that they are seeking, right? If I'm trying to get you to that benefit, I have to minimize the harm. So we build in and maintain that harm reduction principle, but do so from a position that doesn't start with, this is dangerous and bad for you, and here's how we're gonna reduce the risk. It starts from a position of, what can we do to ensure that you are having the best, safest experience for you? And I have been yelled at plenty of times already for even suggesting that. I'm hoping this room is a bit friendlier and not too much yelling for that, but you never know. Happy to hear critiques. We've published this in the International Journal of Drugs Policy. Again, nice QR codes if you want to download that paper. But we called it Harm Reduction Isn't Enough, because I think that's really the ethos that I'm talking about here. Harm reduction is great. I'm in no way dissing harm reduction here, but there is a thing that we need to consider about what comes next. We built harm reduction to fit within that Overton window during Prohibition, where we could say, yeah, please let's keep people from dying. You may not be open to legalizing these drugs or regulating them or making sure they're not toxic, but hey, let's just make sure they're not dying or getting HIV from them. Now is an opportunity for us to move beyond that. And I think that that's where I'll end now and just say, I appreciate the time. Thank you so much to Avikana for having me here. Thank you to my research teams for participating and supporting this work, and look forward to answering any questions.
Thank you for that great presentation and also for sharing your story. I know it's not easy to come up here and share that. And I think it speaks to what a lot of people have gone through, is that stigma, and I'm really encouraged by some of the assets that you guys have built out, and hopefully we can help get that out there so that more people feel comfortable speaking to healthcare providers and getting the right care. And also the last thing being pharmacists. Pharmacists do play a very critical role in care, and we love to see those assets going out there so that they can learn how to prescribe medical cannabis, because today when we speak to pharmacies, they say, oh yeah, people come and ask us, but we don't know what to do next.
Yeah. And we found, I'll just say, I didn't go into the data too much, but we found that a lot of pharmacists are open to and interested in, particularly around medical issues, supporting medical cannabis consumers.